Thank you very much to Maria, to Shahid, to Arjun, to Matt, and to John for some absolutely fascinating talks and being able to break down some very complex topics into really easy to understand ways. So we're going to open up the floor to a discussion, so please feel free to come to the microphones. And, oh boy, we've got quite a few people looking to ask questions. We'll start with
Oh, we can start ourselves.
Yeah, we can do.
Can I start?
Yeah. John, it sounds like you have a question, John.
I'd like to start, please. The question for the epidemiologists. That's you two. So really, really interesting. So and it's understood about the fact that people who have hepatitis get screened. Was there a hint of that in people with cirrhosis anyway, who get screened?
So with the analysis that we carried out, we didn't assess cirrhosis as a risk factor. It wasn't available on the platform we were utilizing. There was something we kind of took as a placeholder in alcohol-specific mortality was a specific risk factor, which we took as a placeholder for alcohol usage. But the multivariable analysis knocked it out of the system, so it wasn't actually part of it.
The answer is no. Interesting.
But we know that during that time frame, that was the era of the DAAs, directly acting antivirals, and revolution in Hep C treatment, which were all carried out by delivery networks with a hub-and-spoke model. There was active screening to find patients. And we know that if you had Hep B or Hep C, you were likely to be found, diagnosed with it, referred to a centre and be treated and have your liver tests done regularly.
Part B, the pollution thing. I mean, polluted areas tend to be poor areas. Was that a confounding variable?
Yeah, so socioeconomic levels will be a confounding variable there. And I think that's where it's really difficult to tell what is really going on with such a small sample size of only the 21 cancer alliances we had. If you go deeper and deeper, even if you went down to the personal level, that's where you really start to see relationships. So as soon as we can kind of go deeper, even down to the 153 counties, that would give us a better idea, because even within potentially cancer alliances which are poorer areas with higher pollution, we would be able to see in particular, well, overall, sure, these areas are maybe all are slightly poorer, but these ones in particular have high rates of pollution, and these ones also have high rates of cholangiocarcinoma. So it would be interesting to see if we could delve a bit deeper into this assistance.
Thank you.
All right. So if we could just open this up to the floor, if you could just, if you're at the mic, explain your name and where you come from, but I don't think you need any introduction, Helen.
Thank you very much. Well, I will just say for everybody, I am Helen from AMMF. Well, thank you to everyone. What a tour de force this session has been. And Matt, you make molecular profiling so clear, even I can understand it. Thank you for that. But I'm going to come back to Arjun and Shahid, and you were really put on the spot doing that presentation, Arjun. That was really, very, very good. But is the pollution thing that John has raised. Now, Shahid can remind me, but I believe that some years ago, Mireille Toledano did some work at Imperial on, and I'm going to call it hotspots across the UK for cholangiocarcinoma, which showed that it was rural areas of high agricultural use that had the most incidence of cholangiocarcinoma. That work was never published, but I think maybe we should resurrect it and have a look at it in comparison with these pollution statistics.
Yeah, so I was hoping Arjun would answer all the difficult questions. I taught him everything I know. It didn't take very long. But so that study that we did with Mireille was, it was about 20 odd years ago. And actually the areas are sort of similar to what we found 25 years later. How we explore the environmental theories actually is very difficult to do. So we have had discussions about, can we look at soil concentrations? Is there... that sort of data isn't really available. It's very difficult to then take that forward and say, well, if there are areas that of high incidence where it's related possibly to some sort of environmental toxin, whether that's in the soil or the air or the water. We haven't figured out a way to actually look at that. Very open to ideas.
Well, I won't hog the microphone any longer, but I do have some thoughts, and I'll come back to them.
Okay.
Julien Guillen, medical oncologist in Rennes, France. This is also a question for the epidemiologist about the contra-intuitive inverse correlation between viral hepatitis and mortality. You also have data on cholangiocarcinoma incidence. So did you look at that?
Yes, so we did look at incidence compared to same number of risk factors, and what we found was that again with our stepwise linear regression model, it kicked out a number of these risk factors. Both viral hepatitis B and C were kicked out from the model, and again it's quite difficult because it would be interesting to see that, but simply due to the really low data resolution that we had during this study, we can't really get a good low. So yeah, what did come back significant there was alcohol-specific mortality, which we took as a marker of overall alcohol use in a given area, which has been tied to chronic liver disease, which in turn, with cholangio. So there is a potential association there.
But at the same time, we know that the majority of patients with cholangiocarcinoma in the Western world don't actually have pre-existing liver disease, unlike HCC. So, yeah.
Thank you.
Benjamin.
Hello, I'm Benjamin Carey. I'm a patient. Personally, I was really interested in what Professor Hawkins was saying about radiotherapy, and I've read a lot recently, and I may come and find you later to ask about that. But my question just now is for Dr. Evans. Professor Bridgewater had a nice slide about the value of liquid biopsy. I was involved in the campaign to get to Scottish Government funding molecular profiling in Scotland, and liquid biopsy is not part of the protocol. There's a lot of anecdotal evidence from patients who say that they are finding that their solid biopsies, resected tumours, are not throwing up anything, and then a few years later they get liquid biopsies which suddenly says they've got 2 or 3 really interesting mutations which can be targeted, and there is hope for them. At the moment, liquid biopsies are not standard. Do you think there might be standardisation of the availability of liquid biopsies? There's also the problem with sort of false negatives with people where there's not enough circulating tumour, and so you won't get anything, but it looks quite promising.
It does, and I can only really speak about this from the English perspective. I've got a bias there. This is being looked at by NHS England, so there's a network of excellence looking at circulating biomarkers operating out of the Marsden actually, and biliary cancers are being explored within that, as well as carcinoma of unknown primary. The issue is not so much technical, because we now have 3 GLHs in England which are offering ctDNA testing for lung and breast cancer. There are snags, but it's going well and we're learning a lot in the process. The challenge will be the funding of it. In lung cancer, which has actually been very, very successful from a circulating tumour DNA perspective, a liquid biopsy perspective, the benefits are obvious. The problem is that the economics don't stack up unless you don't go through the solid tissue process, and that is logistically extremely challenging, because if you wait, you delay things, you cause problems. So I think, sorry, this isn't a very insightful point, but it's going to come down to the cash, I think. There is certainly the will there, and it's technically feasible.
Yeah, thank you.
Dr. Lin from National Taiwan University Cancer Center. And one question to Dr. Evans. Thanks for your talk. Could you please kindly provide some thought about the clinical potential of mass spectrometry-based proteomics or other quantitative methods such as AI pathology in profiling pediatric cancer. Taking HER2 expression as an example, we know that the traditional semi-quantitative IHC results have been challenged by several HER2-directed ADCs, and we all believe that the similar problem will be definitely happen in the field of pediatric cancer treatment.
Absolutely. Mass spectrometry is something which hasn't received very much attention. It's been drowned out a lot by immunohistochemistry. Having said that, we are doing a little bit of work in the West Midlands looking into it. I guess the problem is inertia more than anything else. The inertia is that you assess for proteins using immunohistochemistry, and our systems have all been developed to deliver that clinically. And whenever you're in that kind of position, it's very difficult to decelerate that and change course into something like mass spectrometry. And certainly the drug companies are interested in immunohistochemistry as their target. So I guess my practical answer to that question would be yes, there is evidence that you can use mass spectrometry to quantify proteins, and in some respects it may be a superior approach, particularly compared to eyeballing an IHC stained slide. The problem is building the infrastructure in a real-life health system to deliver a very, I wouldn't say novel, but a very unfamiliar type of testing in that setting. But there's certainly promise there.
And maybe the standardization and how to validate the cutoff may be also a problem, and how to define the clinical meaningful cutoff need a lot of collaboration
Absolutely.
from the clinicians.
Yeah. Having said that, I do have a lot of hope for digital algorithms with immunohistochemistry, although I suppose I'm falling into the same trap of inertia there, aren't I?
Professor Benales.
Thank you very much. Well, first of all, a very nice panel and presentations. Well, my comment and question is on the epidemiological aspects. We had the chance yesterday with Sahid to discuss some of the data from the Basque Country. We have initiated a prospective epidemiological study in 2014, already 10 years, prospective analysis, because our hospital is the tertiary hospital of the community of 1 million people. And we are very concerned, as you and many others, on the rising incidence and mortality. And we don't know the reasons in principle. You commented some potential risk factors that might be associated. And what we found is that according to the WHO, we triplicate the cases in the prospective case. So we have around 6 cases per 100,000 inhabitants in terms of incidence and mortality, which triplicates the data from the WHO for Spain. Mm-hmm. And since the prospective phase, so since 2014, the data is stable, doesn't change. So there is an increase in the retrospective phase from 2010 to 2014 in our hospital, in the retrospective phase, and then it's completely stable. And the risk factors associated, hepatitis, obesity, muscle D, PSC, all maintain the same proportion over time. So that's indicated that, at least in our population, is more an awareness aspect, a better coding and better diagnosis, what makes that rise the case, no? So there has not this big association with risk factors so far, increasing trends of risk factors and then higher incidence. So it's more a matter of better coding, better diagnosis, and more awareness. I would like to know your comments on that. Thank you.
So, yeah, so I think undoubtedly part of the change in epidemiology is from the end of the hospital end, so diagnosis, coding. But I don't think that's the full story, because for several reasons. For example, there was a study about 20 years ago in Journal of Hepatology done in the US where that was the hypothesis. And so they looked at stage of cancer at diagnosis over a 20-year period. And the theory was that if it's all better diagnosis, better coding, then in theory, we should be getting the proportion of earlier stage tumours should increase over time. But that didn't happen. In the study that we did in the UK, when we looked at routes to diagnosis, about 50% of patients still present as an emergency, and that hasn't really changed over the last 15 years. The proportion of patients having histology has improved a little bit, but we have got better at things like CUP. We lost a lot of information on primary liver cancers for a decade when we were doing, when we were not biopsying tumours in the context of cirrhosis, because if they had contrast enhancement, we said, well, it's an HCC, we don't need to biopsy. So I think we're quite far behind. So I think it is quite a complex picture. But yeah, so rates are, in the studies that keep coming out, we have another one coming out in J. Hepatol, rates are sort of going up a little bit, but I agree they are starting to plateau.
And regarding the subtypes, just very briefly, the big proportion that we see of cases are intrahepatic compared to perihilar and distal. So around 45% are intrahepatic over the 10-year period. So, and the coding, the new coding system is very important to see potential.
But in your study, what might be interesting to do, so going back to what Helen was saying about this toxin theory, right? It probably isn't the case that there's one toxin that we highlight, oh, it's cadmium or it's this chemical that's causing it. Probably more likely, in my opinion, is that there's a toxin burden which causes some DNA damage, and then one's genetic profile in terms of your DNA repair enzymes or whatever, and there's a balance between that rather than there being one possible toxin. And some years ago, I published a paper in Gut where we looked at DNA adducts, which are a sort of chemical signature for DNA damage from toxins. And that was higher in patients with biliary tract cancer than other things. I don't think there's going to be like one sort of silver bullet toxin that will do it, probably. We probably need to come to the end.
I think so. I think we need to come to the end of this
we
session.
We do
it's time
need to
for a
come
tea
to
break.
the end, yes.
So thank you very much to Maria, to Shahid, to Arjun, to Matt, and to John for an absolutely fascinating session.